The checkpoint inhibitors for non-small cell lung cancer, the ones that are approved now, are all targeting the PD-1 or PD-L1 pathway. And so the PD-1, PD-L1 is one of the important negative regulators of the immune system. It's something that many tumors use as a way to escape immune detection. It's also an important component of self-tolerance. So it's something that our normal cells use to evade immune detection and reaction. What was discovered was that if we block either the PD-1 or the PD-L1, tumors that are using that as their mechanism of hiding from the immune system are better detected and better attacked by the immune system. Of course, the side effect profile of all of these drugs relates to that as well, because if a normal cell is also using that as the primary mechanism of avoiding immune detection and you block it, then you can get autoimmunity, and that's what we continually watch for with these drugs is rates of autoimmunity and risks from that. What was reassuring as these drugs were developed was that the rates of autoimmunity were much lower than we thought that they would be. So the immune-related adverse events were lower than the initial fears. And that's continued on, that we found relative safety with these drugs. There are 2 PD-1 drugs that are approved in lung cancer now, so pembrolizumab and nivolumab, and now 2 PD-L1 drugs. Atezolizumab was the first, and now durvalumab. Theoretically, they might be a little bit different. Practically, the responses that have been seen, the side effects have been relatively similar. The initial indication was for patients who had already had chemotherapy and then were treated with a checkpoint inhibitor, and there were head-to-head trials with most of those drugs looking at single-agent chemo versus checkpoint drug. In the second-line setting in unselected patients, the response rates aren't that different, but the progression-free survival was markedly better in all of the trials, and overall survival was, well, the progression-free survival was not always that much better, but the overall survival was markedly better, and that's what led to the initial approvals. The expansions that have happened have been looking at specific subgroups and then in different patient populations. So looking into first line, so usually if we get drugs that work second line, we want to then see, okay, can we bring them into first line? And in that setting, for patients who have high PD-L1 levels on their tumor, pembrolizumab alone was better than chemotherapy alone. Very, very recently, in April of 2018, there was data looking at a combination of nivolumab with a different checkpoint inhibitor, a CTLA-4 inhibitor, ipilimumab, that combination versus chemotherapy for patients with high tumor mutation burden, and that also showed that that combination was superior to chemo. Also in April 2018, there was data from the Keynote 189 looking at checkpoint inhibitor plus chemo versus chemo alone for all comers, regardless of PD-L1 level, also showing superiority in overall survival in that study for the 3-drug as opposed to just chemotherapy regimen. That was just in adenocarcinoma patients. And there are more trials that will be coming out. So the mechanism is to increase the immune detection of the tumor by taking away one of the negative regulators. The data looking at the combinations with chemo hint at the fact that perhaps it's if you get a better antigen release because you're getting cell kill for other reasons, that allows the immune system to better detect the tumor. So that was the rationale for the chemo combination. It's also been the rationale for some combinations with radiation that are in earlier trials. And it was the rationale for the Pacific trial, which was for patients who were getting chemotherapy and radiation at the same time, better antigen release, and then not concurrently, but right after, then starting the durvalumab. And so that trial also was strikingly positive. For PFS, we don't yet have the overall survival data. So that's really how we think about how the drugs work. Of course, it's much more complicated because it's the immune system. And it's also helping us to think about what the toxicities are, and also the rationale for bringing it earlier. So these drugs by themselves, for patients who've already had a lot of treatments, the benefit's probably only about 20% of patients. When you bring it into first line, at least with the pembrolizumab, the levels, patients who have tumors with the PD-L1 greater than 50%, it's around a third of patients. And so in that third of patients, the response rates to pembrolizumab were over 50% high rates of benefit. Now that we're adding in chemo plus pembrolizumab for patients who have never had any treatment before, the response rates of all 3 drugs are very, very high with high PD-L1 and reasonable even without the PD-L1, with the survival benefit seen in all groups. And then in Pacific, in the stage 3, we're also seeing benefit regardless of PD-L1 level. We don't know about survival, but at least that PFS benefit. And then even earlier would be patients who have potentially resectable disease. And so there was data with nivolumab as a neoadjuvant, so before surgery, in a small cohort of patients, just 21 patients, but they had significant benefit as far as what they called a major pathological response. So even though if it didn't shrink on imaging when the tumor was resected, a lot of the tumors were already dead. And the data so far on survival from that cohort looks good, but again, it's small numbers. So now where the kind of cutting edge is still exploring more in advanced stage, but also for early stage patients looking at, are there ways to give these drugs before surgery or after surgery? And there are a lot of these adjuvant trials after surgical resection. We don't have that data yet. There is some positive data in melanoma, but we don't yet know for lung cancer.